Dr. Sejal, good morning. I'm Dr. Srihari.
Yeah, just a minute, Dr. Srihari, 1 minute. The mouse has got disconnected. 1 minute.
Okay, well, that I'll just.
Yeah, you can address, yes.
Yeah. So, good morning, all. It is again a wonderful day for us. This is a new initiative. We are trying to do some sort of a testing that on our knowledge that we have learned um, for the last couple of classes. Uh, I must I must congratulate Amrita and especially Ms. Beulah for developing such a platform for organizing a quiz program. There are about 34 candidates, participants for this program. They had attempted and well scored. The scores and the winners will be declared by Dr. Sejal towards the end of the session today. Uh, there are some good things and some like the negatives and positives. We didn't see much participation from the postgraduates against the expectations, especially from the larger medical colleges like SAT and IMCH. We expected a lot more participation. The good thing was that there were very good participation from some of the seniors. They were very eager to attend, and the some of the units under health department, the health services, were actively participated. So that's a positive thing that I'm seeing, and I urge all of you to be part of these type of endeavors in the future also. I must congratulate all of you. I must thank Dr. Sejal for spending the time to develop the quiz program. Uh, Thank you all once again. I welcome Dr. Sejal to have the session.
Thank you so much, Dr. Srihari. Thank you. So friends, we are just going to go through the question and the answers today for the quiz. So if any one of you has any questions while we are discussing this quiz question answers, please let me know. We can rediscuss or even go back to the theoretical discussion with figures to try to understand it in a better way. So we move on to the first question. In the ECG paper, there are horizontal and vertical axes. The horizontal axis measures what? So all of us know that the ECG paper moves at a particular speed. And what it does is it measures the time in the horizontal axis. And what information we get in vertical axis is regarding the voltage. I hope there is no confusion. Here the parameter of speed was given because the movement of the ECG paper happens in respect to a particular speed. So normally if it is 25 millimeters per second speed of the ECG paper, then the time duration is decided based on that. But the parameter which is measured is the time. I hope it is clear. We will move on to the next quiz question. The next question is related to the leads attached to both the planes. So as we know, we have unipolar leads. So the question is whether is it present in the frontal plane? Is it present in the axial plane? Is it present in the frontal and the axial planes both? Or is it not present in either of the planes? So the answer is that it is present in both the planes, frontal and axial planes. Unipolar means we have only one polarity to that lead, and as we know, the augmented leads and the leads V1 to V6, all of them are unipolar leads, and hence the answer is we have it both in the frontal and the axial plane. We'll move on to the third question. We can use ECG to diagnose what hypertrophy? Can we diagnose atrial hypertrophy? Can we diagnose ventricular hypertrophy? Can we diagnose both atrial and ventricular hypertrophy? Or none? So the answer is we can diagnose ventricular hypertrophy, but remember that we cannot diagnose atrial hypertrophy, and that is based on the way the conduction spreads. For the atria and for the ventricles, there is a different way of conduction. For the ventricles, it's from the endocardial to the epicardial surface, and it happens all simultaneously. Whereas for the atria, it is from one place to another. That means it could be from the superior to inferior aspects, posterior to anterior aspect, but it's not from the endocardium to the epicardium, and hence atrial hypertrophy cannot be diagnosed. Coming to the fourth question, the PR interval is measured from beginning of P to beginning of R, end of P to beginning of R, beginning of P to beginning of Q, and end of P to beginning of Q. So the PR interval is measured from beginning of P to beginning of Q, and still we call this as PR interval. You all know that the PQ segment is different than the PR interval. So the PR interval includes the P wave and the part between the P and the Q, and also the Q wave. And hence, in real terms, it's called the PR interval. All the following statements are true except that PR interval changes with age, the QT interval changes with age, the PR interval changes with heart rate, and the QT changes with heart rate.
Excuse me, ma'am.
Yes, Amrita?
Ma'am, can you please come closer to the mic?
Yes. Amrita, now how is it?
Yeah, now it's okay.
It's better?
Yeah.
Okay, fine,
Oh.
fine. So, you know, the PR interval and the QT interval, both are important intervals, and the QT interval does not change with age. So what statements are true except? So the PR interval changes with age, the PR interval changes with heart rate, the QT interval changes with heart rate. But the QT interval does not change with age. So all statements are true except, so this statement is not true. If a vector is perpendicular to a lead, you will get what deflection? So you know that the deflection is based on the direction of vector. And based on that, we decide the axis on ECG. So if a vector is perpendicular, you will get an equiphasic deflection. So if my Q and R are equal in amount, then I know my vector is perpendicular to that lead. The measurement of a terminal negative component of P wave for evaluating left atrial enlargement should be done in which lead? So as you know, the P wave originates from the SA node and then it spreads into the atria, and the initial part of the atrial activation happens in the right atrium and the terminal part happens in the left atrium. So if I want to see the left atrial enlargement, the lead which is going to show it best would be based on which direction my left atrial enlargement is happening. So the answer is V1. As you know, V1 is more directed rightward and anteriorly. So if my terminal P wave vector is directed leftward and posteriorly, then I'm going to have a maximum negative deflection in lead V1. Presence of Q wave in V1 suggests what? All of you know that normally we should have Q wave in lead V6 and not in lead V1. But if it is seen in lead V1, then what should I suspect? So the answer is right ventricular hypertrophy. The Q waves are based on the way the ventricular depolarization, the initial component happens. That means the interventricular septal depolarization. So if I have significant right ventricular hypertrophy, my interventricular septum is going to be deviated in the opposite direction. The orientation is going to be in the opposite direction. Remember, in dextroposition, the ventricular looping is expected to be D-loop. That means my right ventricle is on the right of left ventricle, and hence my Q wave presence will not change. So the answer is right ventricular hypertrophy. Conventional ECG leads are placed in two planes, the frontal plane and the axial plane. The leads in the axial plane tells us about what relationship? You know that the frontal plane tells you about superior-inferior and right-left relationship. The leads in the axial plane, which are from V1 to V6, tell us about the entero-posterior relationship and the right to left relationship. As you know, V1 to V6, V1 is directed anteriorly and rightwards, and V6 is directed leftward and almost at leftward. So it's more right-left relationship and entero-posterior relationship. Every lead is oriented towards an area of the heart. So the leads which are oriented towards the superior left lateral wall of the heart are which? Superior and left lateral. So basically it is leftward and superior. And the answer is lead 1, which is at 0 degrees, and lead AVL, which is minus 30. So these are the leads which are directed leftward and superior. As you know, AVR is plus 130 degrees. V4 to V6 is left lateral isolated. Lead 1 and V6 lateral and superior. In an ECG paper, generally one small square is how many seconds? This is again based on the fact that commonly the ECG paper moves at 25 millimeters per second. So with that, the answer is 0.04 seconds for 1 millimeter. Or it is 0.04 seconds for one small square, or it is 0.2 seconds for one large square. ECG does not demonstrate which part of the cardiac cycle. Is it ventricular repolarization, ventricular depolarization, atrial depolarization, or atrial repolarization? And the answer is atrial repolarization. As we understand, the P wave demonstrates the atrial depolarization, the QRS is the ventricular depolarization, and the T wave is ventricular repolarization. Atrial repolarization is not demonstrated on a surface ECG. P wave is formed by atrial activation. So now we need to decide which of the following statement is true. So all the statements are false except which one? RA and LA activation starts together. RA and LA activations are directed leftward. The impulse reaches the AV node before the RA activation is completed, or the impulse reaches the AV node before the LA activation is completed. So which statement is true? And the answer is the impulse reaches the AV node before the LA activation is completed. So as you know, the RA activation completes, and during the process of RA activation, the LA activation starts. And hence, before the LA activation completes, the AV node is already activated. The RA and the LA activations do not start together. They are not directed leftward isolated, and the impulse does not reach the AV node before the right atrial activation is completed. So the statement which is true is this: the impulse reaches the AV node before the left atrial activation is completed. Okay, I think there is a thing here. I think I have missed writing the question here. The RA activation is directed anteriorly and LA activation is directed posteriorly. So which of the statement is true? Or the RA activation is directed rightward and LA activation is leftward, or RA and LA activations are directed anteriorly, or RA activation is directed leftward and LA rightward. So the true answer is RA activation is directed anteriorly and LA activation is directed posteriorly. In infants, the RS ratio is large in right precordial leads and small in left precordial leads, or small in right precordial leads and large in right precordial leads, or large in RPL and LPL, or small in RPL and LPL. So the answer is it is large in right precordial leads and small in left precordial lead. So the RS ratio is one ratio which gets affected with age. At a younger age, you have a prominent R wave in V1 and a small R wave in V6. But in an adult, it's the other way. You have a prominent S wave in right precordial leads and a prominent R wave in left precordial lead. Normally, Q wave is present in V1 and absent in V6, or is it present in V6 and absent in V1, or is it present in V1 and AVL, or is it absent in 1 and V6? I think this was an easy one. You know that it is present in V6 and it's absent in V1. Now, if a vector is parallel to a lead, then the lead will have what sort of a deflection? Will it have a maximum upright deflection? Will it have an equiphasic deflection, or a null deflection, or it can have any of the above? So if a vector is parallel, it will have the maximum upright deflection. All statements are true except lead 1 and AVF are perpendicular, lead 2 and AVL are perpendicular, leads AVR and AVL are perpendicular, and lead 3 and AVR are perpendicular. So the answer is leads AVR and AVL are perpendicular is not right. The rest three combinations are perpendicular and we can use them for calculation of cardiac axis. Decide which of the following statement is false. The P wave axis of 120 degrees can be seen in the frontal plane if the arm electrodes are reversed. Or wide QRST angle can be seen in aortic regurgitation. Or presence of QR and V1 in a newborn suggests RVH. Or the T wave in V1 must be upright in an adult. So which of the statement is false? So the answer is wide QRST angle cannot be seen in aortic regurgitation. The wide QRST angle means you have a ventricular strain pattern, and that is not seen generally in aortic regurgitation. The P wave axis normally is 40 to 60 degrees. If it becomes rightward and downward, that means 120 degrees. It can happen in mirror image dextrocardia with situs inversus, and it can also happen if the arm electrodes are reversed. Does suggest right ventricular hypertrophy and presence of T wave in V1. Upper right is normal in an adult. Now in this ECG, we need to find the QRS axis. So the QRS axis is what in this? 90 degrees, 30 degrees, 60 degrees or 120 degrees. So you can see here 90 degrees is 0 degrees, 30 and 60 is more in the left lower quadrant, and 120 degrees is in the right lower quadrant. So if we try to find out the quadrant first, if we can see lead 1 and AVF both are positive, and hence it's in the left lower quadrant. So you will narrow down your understanding to the B and the C options. Further, you can see that lead 2 is more positive than lead 1, so it's more towards 60 degrees. So the answer is 60 degrees. Here the P wave axis is, so again we go to lead 1 and lead AVF, and we can see here that lead AVF is negative and lead 1 looks almost equiphasic. So we really not sure, but it could be the left upper or the right upper quadrant. Then we go to lead 2 and 3 where it is negative. So we know that it is more upward. And then we go to AVR and AVL, and we can see here that AVR is not very well appreciated, but AVL is positive. So we know that this is not a normal axis. This is not a right axis, but it is a superior axis. This commonly is seen when you have the pacemaker site which is closer to the AV node and the atrial activation is happening in a retrograde fashion. Here we need to find out the QRS and the T wave axis. So let's see in the frontal plane, the QRS axis, it's positive in lead 1 and it's maybe equivocal in AVF. So it's going to be more closer to 0 degrees. It's also positive in AVL, which is closer to lead 1. So it goes in favor of QRS axis, which is closer to 0 degrees. Now we look at the T wave axis. It is negative in 1 and positive in AVF. That means it is in the right lower quadrant. Again to see the lead, again to double check it, it's in the right lower quadrant. You can see a clear negative wave in AVL. That means it is exactly opposite to the direction of AVL, which is again the right lower quadrant. And you can see here in lead 3, you have strong positive T waves, and hence it's approximately 120 degrees. So the QRS 0, T wave 0 is not right. QRS 90, T wave 90 is not right. The QRS of 0 and T wave of 90 is probably going to be the answer. And this means that the QRS and the T wave axis are separated by more than 60 to 90 degrees, and this is wide QRST angle. And you can see here that you have left ventricular hypertrophy, which could be related to severe aortic stenosis, and hence you have a ventricular strain pattern. All of the following statements are true except the normal mean P wave axis is 40 to 60 degrees. Less than 0 degrees suggests a nodal rhythm or a low atrial pacemaker. 120 to 150 degrees suggests mirror image dextrocardia for P wave, and P wave axis can be decided based on QRS. So the right answer is D. That means P wave axis should never be decided based on the QRS. The normal P wave axis is 40 to 60, and less than 0 degree could suggest a low atrial pacemaker. This is something which we already discussed. The T wave axis moves towards the pathology, away from the pathology, does not depend on the pathology, and depends.
Yeah, yes, ma'am. We can hear.
Okay, I'll share it. Thanks, coming. Okay, you go. Thank you. Yeah. So sorry for the interruption. We come to exercise 24. So the question was, the T wave axis moves away from the pathology towards the pathology or does not depend on the pathology. So the answer is that it moves away from the pathology. Always remember, the ST segment moves towards the pathology and T wave axis moves away from the pathology. And the last question for the quiz was, all the following statements are true except. QRST angle relates to ventricular depolarization to repolarization, QRST angle normally more than 60 degrees. QRST angle does not normally exceed more than 60 degrees in older children. While QRST angle is more significant if the T wave axis is normal, then the T wave axis is abnormal. And while QRST angle is commonly seen in aortic regurgitation. So which of the following statement is true? Or which of all the following statements are false except which one? Okay, I think there is a mistake here. It should be that while QRST angle is commonly seen in aortic regurgitation is actually false. So actually the answer is QRST angle relates the ventricular depolarization to repolarization. That's the right answer. Sorry for this. The answer is QRST angle relates ventricular depolarization to repolarization. And the rest of the statements are false. The QRST angle normally should not exceed more than 60 degrees. The QRST angle has its significance, but not over the T axis. And the QRST angle is commonly not wide in aortic regurgitation. So the answer should be QRST relates ventricular depolarization to repolarization. So now I think we are at the end of the quiz answers, and if anybody has any questions, feel free to ask. And after that, we will be announcing the results for the quiz. I understand that the participation has been a little on the lesser side, but nonetheless, congratulations to all of you for attempting this. And I think it has been a learning journey for all of us. So I hope all of you were benefited by the ECG sessions and also by the quiz, just in a way to brainstorm all of you. So is anybody having any questions? So I think we will announce the results, and I probably would not take the 25th one because the marking of the answer was not right. So many of you would have actually written the correct answer, which is A. So out of 24, we will consider our score today. And I think all of you have done wonderfully. The second prize, so the second prize goes to two candidates. One is Dr. Neetu from Sept Hospital, Trivandrum. And second is Dr. Basima Rahim from Thrissur Medical College. So congratulations Dr. Neetu and Dr. Basima for holding the second position, and your score has been excellent. The first prize is for Dr. Kiran from Paripalli Medical College, Kollam. And you also have scored wonderfully in the quiz. Dr. Kiran, congratulations from Kollam. And congratulations to every single participant who participated in the quiz yesterday. So if we have no questions.
Any questions? Any questions or doubts regarding normal ECG? Thank you, ma'am. Thank you, Dr.
Okay,
Sejal.
thanks, Amrita. Thank you.
And congratulations to all the winners.
Have a nice day.
Thank you.